This is the general assessment and vital signs flow. Your general assessment actually begins when you walk into the room. You can see the patient and see if they're in any distress almost immediately. You also pick up a level of alertness immediately. So are they making contact with you? Are they greeting you? Are they talking appropriately, answering questions appropriately? This all occurs during your history taking as well. What else can you see with a general assessment? Well, posture. What is the position of comfort? You can detect that. Look at the general color. I can see her legs, her arms, and her face. Is it symmetrical side to side? I can also do some general development here. Are the legs of equal length? Do the muscle mass on each side of the body look same? How about the forearms, neck symmetry, and head and facial symmetry? You can pick up those things. Besides that, you can see a general state of nutrition and hygiene. Is the patient actually taking care of themselves? So all that happens in a very brief period of time, and you do it just by walking in and seeing the patient. The second part of it is the vital signs. You do want to think about temperatures as they're recorded. And again, the staff usually does the recording for you, but for temperatures, you'd always want to make sure you notice that an oral temperature is the gold standard, whereas an axillary temperature has a measurement that is 1 degree below oral, and a rectal temperature in an infant or pediatric patient, though not done as often as they had been in the past, is 1 degree higher. So then you're ready to move into pulse, respirations, and blood pressure. So what you do at this point is sit beside the patient. Patients won't intentionally try to change their respiratory patterns, but they will accidentally do so. So I always use a combination technique where I'm checking for the pulse and the respirations at the same time, actually respirations first, and then following that by pulse. Getting my equipment out and ready. So sitting beside your patient, place your fingers on the radial pulse, and this arm goes up with my forearm just touching her shoulder. It's not on the top of the shoulder pushing down, it's just on the side. And what this does for me is it gives me two ways to assess respirations. First, while I'm looking at my second hand, I can see peripherally across the top and see the rise and fall of the chest with peripheral vision. But I also get the tactile sensation as she takes a breath. There's a slight movement of my arm with each breath. So calculating the rate per 30 seconds and multiplying by 2 gives me a total rate per minute. If the respiratory rate is too slow or too fast, you can actually count for the full minute, and it gives you a more accurate rate by not having to multiply. When you are doing the respirations, make sure you're doing the rate and the character. How labored is each of the respirations. After I've done respiratory rate, then I can drop my hand down a little bit, still looking at the second hand, and I can now calculate the pulse. So by counting the pulse for 15 seconds and multiplying by 4, I get the full minute rate. And then I'm also feeling character and rhythm. Is the rhythm regular, regularly irregular, or irregular, irregular? And also the character of the pulse. Is it weak, is it normal, or is it bounding? So by doing the respiratory rate first, you're using a little distraction technique, so not, again, trying to change the respiratory pattern, but you can do that subconsciously. Do the respiratory rate, then the pulse rate, you avoid that complication. So that's pulse and respirations, and now you're ready for blood pressure. So the blood pressure cuff is very important, and the first thing that you want to do is make sure you have the right size for the patient's arm. So you ask the patient to expose the arm, and then you have them roll. And don't be afraid to let the patient help you. They are quite capable of just holding their arm up for a few seconds while you're doing this technique. So the first thing you want to do is find the brachial pulse. 80% of the time it'll be located medial to the bicep tendon, and if you have the patient flex her arm up, see as she flexes against my resistance, I can feel the bicep tendon become full. Dip right over the top of that and relax your arm again, and you can find the brachial pulse. Again, 80% of the time medial to the biceps tendon. Technique to make it pop out is actually somebody has a thicker arm, you can hyperextend the arm and it brings that artery closer to the surface. You might be able to find it easier that way. 20% of the time it'll be lateral to the brachial. 20% of the time it'll be lateral to the biceps tendon. So once you've found the artery, now you know it's there, you don't have to hold it, you understand where it's at. Pick up your cuff, and this is the artery marker. It tells you exactly where to put it. So don't put it over here, that's not where the artery was. Bring it over to the center, placing it medial to the bicep tendon, that's where we found it. And then you wrap the cuff around, and you see this range marker on the inside. The little cuffs will be different, but in this case, it has the marker right here, the index, and as that wraps around, the artery marker should fall within the range. In this case, it does. So once that's in place, you're making sure that you allow it about at least 2 centimeters. This is nice, we have long upper arm so we can give as much area as possible for our stethoscope head to be placed here. Now you don't want to start taking the blood pressure right away. A lot of times people put the stethoscope on there and they just auscultate. You have to be concerned about what's called an oscillatory gap, and that's the phenomenon where even though you are listening, you cannot hear any pulse rate, but the systolic blood pressure is actually higher than that. So to avoid missing an oscillatory gap, put your hands on the radial pulse again, and you pump this up to about 100, and you see if you still have a pulse. Small pump above that, about 110, 120, and her pulse is already gone, so I can leave it back out. So about 110, her pulse disappeared. Now what I do is let that air out, and again, that took about 5-10 seconds at the most. You don't want to keep that pumped up for too long. Once I get that disappeared pulse, let the air out rapidly, and now I'm ready to do the auscultation. Stethoscope. Remember, the ear canals go anteriorly, so that's how you'd put your stethoscope into your ears. And this technique is called the cross-arm technique, where I pick up the patient's arm, rest it on my forearm, place my stethoscope head over the medial part of her antecubital space. Some stethoscopes used to be non-tunable, which means that you could hear out both sides. Most stethoscopes made today, this side is open. I can hear on this side, but if I tap that side, there's no sound there. So now I can put my thumb on top. Otherwise, you used to have to put your hands on each side instead of on the back. This one I can put on the back. And now I'm going to repump up the blood pressure cuff to 20 millimeters above what it disappeared at with my palpatory technique. So it disappeared at 110. Now I'm going to go to 130. So I'm there, and then I just very gently open up the valve, see when the first pulse comes in. And I'm dropping about 2 or 3 millimeters per second. Pulse came in at about 108. And then I'm listening for the last pulse, and I hear the last beat around 60. So her blood pressure is 108/60. And that is your blood pressure measurement.